And I'm going to as well on the Zoom, I'm going to record this. So we have 2 records of it. This somebody's listening, making sure that I guess we are live. Let me see, actually go to the Zoom window. So we see ourselves, got it. So this is the live window and we are all in the frame. John, you may want to come a little closer. Okay. Yeah, get closer to Mike. So, welcome to Essence of Medicine. And this episode is about a very special kind of spine procedure where it's very much efficient and a groundbreaking technique, but I'm always asked why not everybody's doing that. I'm Dr. Abbasi. I'm a neurosurgeon specializing in minimal invasive spine surgery. I'm performing this procedure for last 10 years.
I'm Ken Barra, mechanical engineer, medical device design, and I was part of the team that developed the OLLIF.
Mike Hansen, Vice President of Marketing. My job is to basically get the word out of the superiority of OLLIF versus traditional lumbar fusions.
And I am John Siegel. I am the CEO of Inspired Spine, which is advancing this technique to make it the standard of care for lumbar fusions.
And I'm sure that it's very clear that we are disclosing our relationship to this procedure and that obviously we do believe in this. That's why we are doing what we are doing. But why don't I start with my cases yesterday? John, you are in charge of monitoring all those cases, how they are done, how they are performed, what are the results. That's one of your core competency to make sure the results that you say to the patient are truly the result that we deliver.
Correct. In fact, one of the things, and this is where I work very closely with Mike, is we essentially advertise these results to increase the demand for the standard of care. Hence, they need to be consistent and reliable.
Yeah, and those results are collected very meticulously with your team, Ken. And once in a while, you and I have this conversation, how emotional I am almost about when the data are not collected meticulously. And you and I have had that conversation over the last 6 years, maybe 5 years, very, very clearly. And Mike, as well, you advertise this result to the patient.
Correct.
And we have decided to go to patient directly with this result. And practically, we try to go to surgeon, universities, places, but we decided to go to the patient directly. Do you want to just summarize about why are we not putting more effort to advertise this to other surgeons or hospitals? Or, we do all of that, but why is our main kind of emphasis is on informing the patient?
Well, I think basically getting the patient informed is very important. Direct-to-consumer marketing is one of our top ways to actually get patients in the door and educate them on how the OLLIF is superior to traditional lumbar fusions. The objections we see from surgeons, we'll probably go through that today, but some of the surgeons that do traditional lumbar fusions are stuck in their ways, and some of them aren't even willing to look at the data. And we've got over 1,600 OLLIF data points that we have collected.
Yeah.
That some surgeons aren't even willing to look at.
Yeah.
Well, and if I could add to that, so from a very high viewpoint, there's 2 primary reasons why there's been resistance to the adoption of this particular technique. One, I believe, is a healthy resistance. The other one, I believe, is not so healthy.
Mm-hmm.
Okay. The first one is that in any medical innovation, there's going to be skepticism, especially spine. Right. There's been a lot of snake oil in the past that's been sold for spine. And this goes back to Dr. Abbasi's point, is that don't take our word for it. We're collecting, we have probably over 220,000 data points for these 1,700 surgery patients. Okay. So, and that's what we're going to talk about today.
Yeah. And our database, we have I think about 1,600 cases, 1,500 cases or more, just mine. And then we have many from other surgeons as well. I just checked that we have about 28,000 clinic visits for those patients. And we have actually the data point is a point that you start collecting a set of data. We are way over 200,000, 220,000 data points. So, and we have 10 years of experience with that. But I think I'm just going to tell you, and Ken and I, we are going to have another follow-up podcast today, talk about the history of this, how it came to be, which is, I think is very interesting as well. About 2 months into doing OLLIF, I start seeing my patient. And at that point, the results were so different that I knew if I don't believe that, nobody else will believe that. So I started in my busy clinic taking patient testimonials. And meanwhile, last time I checked, we have way over 1,200 patient testimonials at different stages that literally they wake up, the pain is gone, or literally their symptoms are completely gone with a surgery that is tremendously different than what's out there in any place. Now, John, you look over those data and you assure their clarity and their practical accuracy. Can you tell us about the 2 OLLIF cases that we did yesterday in a local hospital?
Sure. The first one was a 3-level, I believe was L2 to L5. The patient actually had a BMI of 45.
And for people who don't know, probably anybody in this here, we have a BMI around 30 and so on. So BMI of 45, for those people who don't know, that is body mass index, your weight divided by your body surface area. Usually anything above 30 is considered, overweight and obese. But then when you go to 35, 40, 45, you are getting to massively obese people. And as a matter of fact, most of our society in the spine just recently recommended not to do any spine surgery for BMI above 40. So the first patient, we did a L2 to 5 OLLIF with a BMI of 45. Hello.
And the results of that, so from a risk profile standpoint, the what's called skin to skin time, so the time from when they make the first incision until the patient is closed, was 77 minutes. So it was 1 hour and 17 minutes for a 3-level, what's called 360 lumbar fusion. The associated blood loss for that case was 150 cc's. Okay, if people don't know the conversion, it's about 30 cc's per ounce. So it's about 5 ounces of blood, which is less than your cup of coffee this morning.
And the second surgery, do you know the results of that?
Second surgery, I believe, was a 2-level.
No, it's as well 3-level. But
The 3-level, yeah, I'm not familiar with the particular results of that.
well, I was there, so I know the results.
I would hope so.
Yeah. So it was a L2 to L5 as well, same levels. Patient was not, the BMI was just about 30, 31, and our blood loss was 50 cc, and skin to skin time was 55 minutes. Now, what's more important is just before I came here, I checked on both patients. Both patients, the leg pain is gone, they're ambulating, and they are ready to go home today. As a matter of fact, you see
24 hours.
Less than 24 hours. And as a matter of fact, you would see in the face of the nurses there that are used to take care of this patient my way and the other way, is how amazed they are again and again that this patient, they're telling me they're doing so great and they're ready to go home. And now for comparison, similar surgery is easily 7 hours, 3-level fusion, easily 7 hours. And people can lose about somewhere between 1,000 to 200 cc of blood for a 3-level interbody fusion. And average hospital stay is for a 3-level. For a 1-level is about 3-4 days, but for 3-level is easily can be somewhere between 4 days and 7 days. Whereas our patients are ready to go home And as well, return to work is so much faster because we don't cause so much damage that patient has to recover from. And practically, I think that is how many patients find us, because they listen to other patients who have gone through the process, and then they want this. They don't want the traditional open old-fashioned surgery. They want this. And naturally, when I'm telling you that something is so much better than anything else out there, the first reaction is, then why is not everybody's doing that? And this is what this podcast is about, to identify the root and the analysis of why in the last 10 years we had difficulty literally to make it a standard of care for everybody, because the data totally supports that this should be the new way of doing spine surgery. Now, coming back to Ken, you have done this even longer than I. With, you were part of the original team that developed this. And I remember when I came to the training, I think that's where we met. And somebody was telling me that this so-called indirect decompression works so beautifully. And I was just laughing inside, not believing, and was hesitant. What did you first tell us what that is, the direct versus indirect decompression?
Well,
meaning that taking the pressure off the nerve in a direct way versus not direct way. What does that mean?
So with the direct decompression, you normally have to go in and remove the bone around the nerve. So you're removing the bone to make a cavity, more space around the nerve. And indirect decompression is separating the two vertebral bodies that then cause that space to increase, that removes the pressure on the nerve, that restores the standard anatomic space that's naturally there around the nerve. So, the comparison is you're restoring the natural anatomic space, or you're carving out the bone where the anatomic space has been collapsed to reestablish a cavity for the nerve to not be compressed.
So practically, I'm just going to make it even a little more here. If you see, imagine this is a patient laying on the belly. This is back and front. And the spinal cord and the nerves are surrounded by bone.
Yes.
And direct decompression is you go and cut the bone.
Right.
Indirect decompression is practically
Move the bone.
move the bone or restore the bone, distance between two vertebrae to bone the way they used to be, because we are all naturally born with the amount of the space that is needed to be there, right? We are not born and we have spinal stenosis or narrowing of the spine. We are born and we live. Eventually, we develop that narrowing, and what's caused narrowing the spine is either the disc or the bone or ligament that goes the wrong way. Or sometimes as well, when the bone collapses like a flat tire, the bulging of the disc is like a flat tire, part of the tire that bulging out, that can push on the nerves. And when I was there, and they told me if I just restore the distance between the bone, practically restore the height to what it used to be, and that is enough to take patient symptoms away. I'll be honest with you, Ken, I didn't believe that. So I came home, Alexandria, and I started doing this surgery very cautiously for people that I thought, these are things that, I still can help them with restoring the height of the disc. And after 2 months, I just couldn't believe what I saw. Because this patient, they told me they woke up and their leg pain was gone. In the surgery, that was 1/3 of the time that I would have needed for the open surgery. With the blood loss, that's 1/10 of the surgery that would have been open old-fashioned way. Imagine, this is about probably 500 cc or about 500 cc, this cup. I'm not sure if it is visible. Let me share the screen so that it's easier visible. And almost everybody can tolerate losing that much blood. Most of healthy people even can tolerate losing
I give that to the Red Cross about every 3 months.
Yeah, here you are. So And, you may have some dizziness and so on, but you drink some fluid and then you'll be fine. Now, we are healthy people. For unhealthy people, with a heart problem or other vascular problem, sometimes that can be, for an elderly person, even that can be a problem. But generally in a hospital, we can compensate for that by giving fluid and other things and so on. Imagine, this is, I barely have ever lost, as a matter of fact, John can test on that. I barely have ever lost that much blood for my OLLIF. As a matter of fact, you guys keeping track on that. There are probably less than that. After doing this for 1,500 cases, probably less than a 10 or so patient that I have lost more than this.
The average for a 4 level is about 200 cc's.
So half of this.
Correct. Average for 4 level. For a 1 level, which about 80% of the cases are 1 or 2 level. Right. The average for a 1 level is about 60
cc.
And the average for a 2 is about 80.
60 cc is like a 1/5 of a cup of coffee, or
2 ounces.
Yeah, about 2 ounces. And what that means that even an elderly person with lots of heart problem, they can tolerate that. You can do that surgery safely for them. And that, I think that's exactly the true difference. Mike, how many times do you get patient, elderly patient from out of state that, you and your team, you answer the first call? How often do you get contact to this patient that have been told no? And do you have any personal experience there when you bring it to the patient regarding this patient, specific this patient group who are elderly and have been told they cannot have spine surgery?
Well, right now we're running about 15 to 20% of our patients are coming from out of state. And from an elderly standpoint, I would say 40% are being told that by other surgeons that they can't do anything. Whether it be that they're too elderly, their BMI might be too high. They're being told that, unless you lose 150 pounds, we can't really do anything. The risk is too much for us.
No, these are people who have been told they cannot have surgery by other surgeons because they're obese or they're elderly or they're marginalized. On the healthcare side, they're marginalized. That's something you might, be able to have a good guess. But Ken, how many? Do you know how many spine surgeries, fusions are performed in the United States last year?
I'd be guessing that 100,000.
What about you, Mike? What do you think? How many spinal fusion are performed in the United States last year?
I'm going to say 500,000.
John?
1.5 million spinal fusions in the US last year.
And I'm going to ask the person who actually looked it up. Amanda is on the background. Amanda, you looked it up. How many spinal surgeries, fusions are performed in the United States in 2021?
1.6 million are performed, and that's not including the patients turned away.
That is patient, not including patient turned away. In a way, I love that you're impervious and you don't know how many are performed because you have to concentrate on making one device the best, not producing it for the mass. But you know what that means? This is a public health issue. This is not some genetic disorder that 50 people in the whole planet have. This is truly public health issue in the United States. As a matter of fact, I think if we don't become more efficient, our healthcare system cannot survive. The number of the spinal problems that need to be taken care of. Now, John, in the last 5-6 years that we have been working together, we have been teaching this to lots of surgeons, or we approach a lot of surgeons, that multiple campaigns to bring this to the patient, hospital, insurances, and so on. Tell me your best experience there and your worst experience there. Because you live there every day. You try to make people understand, people at different capacity. I'm going to ask as well, Mike, about first-hand experience when these people call. What do they tell you first? I'm going to talk to you. You have had lots of experience with lots of surgeons, but you try to bring this to healthcare, to insurances, to hospitals. Tell me your best and worst.
So
experience
I would say my best experience thus far,
Mhm.
and it's still ongoing in terms of the response, was a hospital with whom we formed a partnership that will be commencing in the first quarter of next year. Happens to be in Kansas. The physician-owned hospital, and the management there, when I articulated the value proposition of what this particular technique can do, they got it immediately.
there. What did you tell them and what did they get?
So there's two aspects to it. One are the clinical advantages. So it comes down to the ability that we're able to substantially lower the risk profile of what has historically been what is known as a high acuity surgery, okay, and transform it essentially into a low acuity procedure, right? So they like the fact that we're going to be delivering patients that they would have to treat post-op as though they on par with somebody who might have had a knee replacement.
Mhm,
So not as big of a deal, almost an outpatient, in many cases outpatient.
mhm.
They like that. The other thing that they liked about it is because it's spine, it delivers a high acuity payment.
Yeah.
So from a financial standpoint, it makes a lot of sense.
And what is your, where you start scratching your head and say, I'm throwing a 10 of 10 model at you, and you just don't get it. What was your worst experience that you just, how do I say, you thought you're in Twilight Zone?
Another hospital that I pitched this to, spent a lot of time, started with the CFO, who he seemed to get it, brought in, the C-suite. Everybody loved the presentation. Wow, this makes a lot of sense. We could use this. Okay. Got the medical people involved, and that's where there was absolute concern. Well, we can't do spines this based on their prior paradigm understanding of spine. The nurses and the OR staff didn't want to have anything to do with it. Okay. So I was more than happy to say, you can come watch Dr. Abbasi do this at any time to allay any of those concerns. Well, maybe later. I showed this hospital. What made it one of my worst experiences is that I dug in, demonstrated the opportunity cost of doing our spine surgeries versus doing knee and shoulder replacements. And from an economic standpoint, it wasn't even close. Okay.
Your spine was better.
Much better.
Mhm.
Better. The other thing that I demonstrated to them, so this was a hospital that had a $2.7 million operating loss in 2021.
Now
Okay.
you know why.
So, well, I showed them that with performing 8 a month of this particular procedure with a payer mix of 70% government and 30% commercial would put $4 million of profit
Mhm.
into their coffers.
That is even beyond what the service you can provide to the local community.
That goes well
I
beyond
mean,
that.
we see that is always first. Okay, those hospitals are there, take care of the local community. So
But if they're losing $2 million every year, how much longer
by
can they
not
stay
taking
there?
the care.
Yeah, exactly.
So that is almost like, that is like Twilight Zone. So Mike, people call you and, after, and you have a team that answer, talk to those patients. Tell me some of your experience. That what do you hear that you say, I am doing something that is really positive. What do you hear?
So a majority of the patients that call in, they're seeing some type of marketing initiative, whether it be social media, Google campaigns, or TV. Those are the biggest three. The
And
biggest,
obviously, if I may, in the marketing, everybody's going to say they are the best and so on and so forth.
yeah, and we lay out the features
Yeah.
and benefits of OLLIF, and we compare it with the traditional lumbar fusion, and patients get that. But their first question is, I saw a campaign, and you're claiming that you can do a lumbar fusion in 1 hour. Explain how you can do that. And our phone reps are scripted. They know exactly what to say, basically what we're talking about here today.
What do they say to truly show them that, excuse my French, we are not full of it?
We actually refer a lot of our patients that call in to our testimonials.
Mhm.
So our testimonials are really tell it all. I mean, there's
Yeah.
patients that say, it was an hour surgery and I was released the same day at 2 hours after the surgery was performed. So we basically educate our patients right out of the gate when they call and let them know that, yep, this is true. Go online, check out our testimonials. You'll see over 1,200 people, 1,200 cases that where their success stories are there.
Yeah.
So
It is not, I might feel that it's really not hard to convince the patient because they're the primary beneficiary of the procedure.
I mean, when you let them know that it is truly an hour procedure for a 1 level or even 2 level now for an hour procedure, and they can go back to work in 2 to 4 weeks, it sells them right there. And we've got plenty of patient outcomes and success stories to prove that.
Yeah. Now, I know now we are going to move on to your field because we have been you have been in contact with lots of surgeons,
Yes.
many of them that have been doing it for many years, including like some over 10 years. And tell me about, those surgeons that you have seen transitioning to this versus those surgeons you have been, trying it but not doing it. What is your best and worst experience there? What do you think? What makes some surgeons do it and other surgeons not do it?
I think the surgeons that have been really successful with this are surgeons that they were doing TLIF and doing the MIS TLIF. They're trying to do less invasive surgeries, and they see that this is another step towards being even less invasive, less disruptive of all the muscle and the natural anatomy. So those surgeons that are seeking to be less invasive see this and understand the benefit of that. And surgeons that have the best ability to visualize 3D, they can see on the X-ray what they need to see instead of having to have a large incision to see what's going on.
So
Those are surgeons that are most
surgeon skills definitely play a role.
Being able to visualize what's happening, definitely a 3D spatial eye-hand coordination is important.
Now I really hate to say that, but many times when we don't have the skill set to do something, or we don't have the patient, or we just don't want to do that, we come up with the excuse why this is not the best. And after 10 years, I'm just going to call them excuse.
I'm sure you've heard plenty.
Yeah,
I can come up with 10 of them off the top of my head.
Yeah, and we are going, and that's one of the things we need to talk about. Okay, so because so I'm going to just talk about this objection that we have heard, because we hear that all day long. People, we present them with the data. Many of them flat out they say they don't want to look at the data, which practical tells you they're not genuine. It's nothing genuine about the academician, a surgeon who is presented with the opportunity of a procedure that can cut the blood loss to 1/10, but he does not want to look at the data.
Look at actual data, not just the marketing brochure,
Yeah.
but actual data.
I have a name for them. I call them the LinkedIn warriors.
Yeah, well, I have a name
Because-
for them too. But I'm not going to say it on the podcast.
But they don't want to bleep it out. No, but these are people. I put one of my cases out there, actual patient that has been rejected by 5 surgeons, and have been told you have to live with it. This is actually a patient who's gathering his pills to kill himself. I'm not going to sugarcoat it, because he say, I cannot do anything with my family. I'm just a burden to everybody. I lost my job. I cannot participate. They're gathering their pills to commit suicide. They come to us. We do a 1-hour surgery. Within 3 weeks, they're off narcotic and they're back to their life. I put those results out there, and then somebody comes and argument with me. Well, that is not a grade 2 spondylolisthesis. That is a grade 1. It's 2 millimeters short of a grade 2. And on a picture on a LinkedIn, or the other one says, but that is really not a scoliosis picture because it is a CT. You haven't think, but they totally disregard the human story behind it. What that means for that patient, that by 5 other tests, you say, you're just too big, you're just too old, you're just too fragile, the surgery is too much, I just don't want to do that. Now, you put it out there, and those are LinkedIn warriors that they truly disregard the human misery that is caused by letting those people live in pain. Many of those surgeons, they just to get those patients off their offices, and practically not my problem kind of thing. I'm not going to do the safest thing for the practice, but not for the patient. But some of them, they have legitimate. Let's just talk about those legitimate concerns. I want to share the screen now and go over this legitimate concerns that some have. And that's not something we hear a lot, John. You want to say, you tell them, and then we all comment on that.
Okay.
Go ahead.
So the first objection, or one that we hear quite often, is due to the fact that the surgeon is not securing direct visualization of the pathology or the pathological area, that they're concerned about an increased risk of nerve root irritation and or permanent injury.
And I was a skeptic myself. You have been doing it for a long time. Let's go around and just answer that just in one sentence. Answer that. Let's go four answers. Everybody pick up, and if somebody has said the same thing, you have to come up with a different answers. Yeah, you start.
So in terms of my response to that?
Yeah, well, why don't we start with, technological, marketing, and then you and I go last, okay? You start first.
Okay, well, the pathway to the nerve, you can navigate that. And with our neuromonitoring technology, we can know the relative proximity to the nerve. So you can avoid the nerve, not going directly on it, but even in every traditional spine surgery, you are manipulating the nerve. You're sometimes putting a retractor directly against the nerve to move it out of the way.
Mm-hmm.
So by using our neuromonitoring technology and dilators that go sequential dilators that slowly push the tissue out of the way, you're not touching the nerve. You're going next to the nerve and around the nerve.
How do you answer that to?
Well, from a marketing standpoint, we tout that and tell patients that there is a 15% chance that there could be nerve root irritation, but that's going to go away. And there's proof of that in the data, that's going to go away after a month, 2 months, 3 months down the road. So that's what we tout from a marketing standpoint. And we tell patients that when they schedule the appointment, that, and they're worried about surgery, and they're even educated enough to talk about nerve root irritation. We've got the statistics that show that we're conservative by saying 15% because we're way less than that.
From my perspective, actually, while it might, appear to be an increased risk of nerve root irritation because you're relying on biplanar fluoro, actually, due to the instrumentation that is employed, there's a decreased risk of nerve root irritation because all of the discectomy, the removal of the old disc, which uses very sharp instruments, is done through a portal. And that portal actually protects the nerve root, as well as something known as the dura, which is the lining of the spinal cord, where if the dura is nicked or cut into accidentally, which occurs about 8% of the time in traditional open fusions, you have something known as a cerebral spinal fluid leak. And with respect to the inspired spine OLLIF, or the technique that Dr. Abbasi is talking about, in over 1,600 cases, we've had exactly 0 cerebral spinal fluid leaks, or what is known as a durotomy.
My turn. Your spinal cord and the nerve root are like my hand. My hands are the spinal cord and the nerves that go down, and here is the nerve root that comes out. In a regular surgery, we go here. We push in the axilla of the nerve. We push on the spinal cord and the nerve root. And we put both of them at the danger. As a matter of fact, as John was saying, there's about 7 to 8% risk of poking a hole here in the spinal cord. But as well, we are pushing the nerve root away. In the OLLIF procedure, we are about at the tip of my thumb, far away from the spinal cord. We have 0 risk of putting the spinal cord at danger, but we have what seems to be, in comparison to open surgery, even less risk of damaging the nerve root. And the proof of that, in our study, only 1 patient in 303 patients had after 1 year symptoms, whereas in the open traditional surgery, it has been reported that risk is lowest reported is 0.3, but it has been as well reported up to 35%. In average, 1 to 3% is accepted, where we are far below that. So let's go. But again, this is based on the data. Many people initially, they may have up to 15%, we consent them they may have some irritation of the nerve, but that gets significantly better. So, objection number 2. John, what is that objection? And let's go in the same way over this.
So
Objection.
the second objection is this doc told me this directly as I was driving him to the airport after he witnessed Hamid performing the surgery. He didn't believe, or they don't believe, that they can secure what they think is a sufficient discectomy and end plate preparation through this 8mm ID portal. So they're concerned that they're not going to remove enough of the old disc, as well as scrape off enough of the cortical bone on each side of the vertebral end plates.
So this is your field. Why do you feel comfortable that we can do that?
We use devices that go through the 8mm portal and expand and reach up to 13mm off the axis of that portal. If we're going 13mm to one side of the axis and 13mm to the other side of the axis, we can reach a 26mm wide surface within the end plates.
Mm-hmm.
And routinely, when we're doing our trainings, we collect all the small fragments that are being taken out. And when you take all those small fragments out piece by piece, they don't look like a significant amount. But when you collect them all and you look at them as the whole collection of what's been removed, you can visualize just how much has been removed. Plus, we've done these with endoscopes where we're able to go in and look internally after the procedure has been done. We've done dissections. When we do these in a cadaver, we've done dissection to look in and see the surface of the end plate and see where it's been exposed, where the cartilaginous surface has been removed to expose the cortical bone. And we've substantiated just how wide of a surface area we are preparing.
No, does anybody ask you that question? This is technical, right?
Yeah, from a patient marketing standpoint, we wouldn't want to get this technical, to be honest with you. We'd want them to schedule them, and then any questions that they would have to talk about that with the surgeon.
John, what is your answer to that objection?
In terms of securing a sufficient discectomy,
Yeah.
based on what I was describing earlier, you can secure actually a more aggressive discectomy and remove more of the material due to the fact that nerve root and dura are protected by the portal. In fact, I know that you have actually shown how much of the disc material that you remove. So again, we have data on the volume of disc material.
Okay, my turn. About 5 years ago, I was in a SMIS, Minimal Invasive Congress in Las Vegas. A minimal invasive surgeon told me that in 1998, they tried to do discectomy and preparation of the end plate through a 1 centimeter tube. It's just technically not possible. And my answer to him was that if I try to fly without the wing, it will be impossible. And that's where you are crucial. And you create the tools. Now, I can try to have a fancy dinner with a shovel all day long. It will not be fancy. At the end of the day, that dinner will not be fancy. But that is exactly your job, to create the tool that enable us to do that. And as was John saying, again, imagine my hand being the spinal cord and this is the nerve root. When we go here in a regular surgery, we put them both at danger. So we are very careful. We have to go with sharp instrument in and out here to perform the discectomy. But if you have a tube, that tube goes on once in, and then I can go through the tube, protect it, and perform the discectomy much better. Now, again, there are two facts here. This is one of those moments in spine surgery. Once you get used to it, you can't go back to old way, passing that sharp correct nerve to the dura and cause almost 7 to 8% risk of durotomy. But more importantly, that may come later, is as that movie with Tom Cruise, Jerry Maguire.
Show me the money.
Show me the money. Well, the money is that bone grows in our surgery so much more, so in such a high percentage rate, that is not unheard of in open old-fashioned surgery. So if we couldn't perform the discectomy and prepare the end plates, we couldn't achieve that fusion rate that is confirmed by 2 independent radiologists to be in high 90th percentile. So next point.
the cage footprint is insufficiently sized, aka too small, to prevent what is known as subsidence. So that would be a collapsing of the two vertebrae back towards each other.
So what do you have to say about that, Ken?
Yes, the cage is approximately the same size as a T-lift. So why
That
is
is
the
the point.
T-lift acceptable, but this cage is not?
Yeah, yeah. You know, most of the time that comes from people who perform so-called X-lift or A-lift, right?
Yes, the big
You want to
lateral
describe? You
cages.
want to describe that? What that is and why this is different? And by the way, about 80% of the surgeries still in the United States are performed with the so-called T-lift method, either T-lift or MIS TLIF method, which our cage has same profile almost.
Practically the same surface contact area.
There are about the 10 to 15% other surgeries are performed where we literally open up your belly. I have done a lots of that. We not figuratively, we literally open up your belly, either from the front or side, and then open up the disc, and we put a cage that is substantially bigger, but we have to do a lot more opening and go through a lot of vital structure to put that cage. Risk versus benefit. That's why still 80% of the people are doing what you just described, T-lift.
Right.
Yeah.
Then there's the lateral approach, which goes through the psoas
Yeah.
muscle and has an incidence of causing nerve damage.
Much higher
because
than-
the lumbar plexus.
That's that 35% came from. by the way.
35% that. So any exposure there?
The only question we do get asked, people again that do research, they do ask about the cages that are being put in. And we do tell them it's basically the same one that you would have in an open surgery that would be 4 times as long as this. So that's really the only question we ever get as far as we never get subsidence. It's never
Yeah.
brought up by a patient.
Yeah. Now, what I think what's as well important, you know, when you do an X-lift or A-lift, when you go, they would put big cages. 80–90% of the time, they put it from the front or side, they close it, and they turn you to a second surgery. As a matter of fact, one of our surgeons who come and visit us, that he does this next surgery next day or
Mhm.
few days later. So you get a 2-day surgery that we do in 1 hour. So, John, your turn.
What's my response to this?
Yeah.
My response goes back to similar to your response about the last objection. Let's look at the data. So let's look at the distance between what's known as the pedicles, or, you know, the two vertebrae prior to the surgery. And I believe that we have a CT that shows a 7 millimeter distance. Then we look at it post-op, it's 13 millimeters. 1 month later, 13 millimeters. Six months later, 13 millimeters. A year later, 13 millimeters. No subsidence. So again, I point them back to the data. Say, look, theoretically, I understand that you have a hypothesis, but hypotheses are meant to be tested. So here's the results of that test.
Yeah. And you know, you can be emotional about everything. I was so excited about that, I couldn't hold back. I start giving my answer between your cases. But again, show me the money, show me the data, show me the results. The fact is, in my patient, 12 times I had to go, and that putting the cage in wasn't enough. There was some subsidation and something that required me to go back. And half of them were patients who fell, had an accident, and no surgery is immune to that. And if you compare that to the rate of how many times other surgeries have to take the patient back, we are at a fraction of that. So again, look at the data. One of the things is that I give to all this LinkedIn barrier to get with me online. So I said, I'm going to open to you my raw data. Amanda is sitting here because she's the person who connect me to all these people and so on. From those people who come with this attitude, how many do they come back and take us on that offer? That I take my time off work
I
and
would say 1 in 1.
yeah.
They don't want to work.
Yeah.
Yeah.
One thing they kind of just compare like
Work.
the
Yeah.
bachelor.
Yeah. Again, linking warriors. So let's move on.
So the cage is not sufficiently lordotic that will result in something known as insufficient sagittal alignment that could result in flat back syndrome. And I'll let Hamid explain exactly what that means.
Well, there is a concept in spine surgery that you have to have certain bend to your spine for the maximum benefit or maximum economical situation of your spine. If it's not the case, your muscle have to work harder. That concept comes from scoliosis, deformity surgeries. By the way, Dr. Kim is an expert. Our other colleague is an expert on that, and he put a really nice out there. Amanda, please make sure we put the link to that conversation that Dr. Kim present what those data means. Now, on those apply to typical scoliosis, meaning people who have 7-8 level surgeries and so on. Now, there is another kind of barrier on LinkedIn. We call them the lordosis, because these are mostly young surgeons that almost nothing else matters to them. The lordosis that they can take it from 7 degree to 11 degree, that is all matters to them. But like you may be willing to kill that patient by surgery to make that 7 degree, 11 degree, because you're going to have 2 liter blood loss. Or are you going to give it that chance to an 85-year-old? We call them lordosis surgeon, because that's all they care about. Whereas, but there is a concept that it is a good thing to put the spine in proper bend. I'm not going to, that wasn't my answer yet. So you go ahead, Ken. What is that? What is your answer to lordosis?
It's not lordotic and can't stop you from creating flat back. That's the question.
Yeah.
It's in where you place the cage within the column. Gives you a certain pivot point that can create that lordosis. Whereas some surgeons you mentioned would do a big surgery like a pedicle subtraction osteotomy to create that angulation. You're achieving the same thing by creating an angle, creating a pivot point by the location where you place the center of the cage.
Mm-hmm. So practically by location of the cage, you can create lordosis.
Yes.
Do we have data for that?
We do.
We have a lot of pictures. We do. Anything on your side, Mike?
No, I mean, just doing this presentation, I've learned a lot about lordosis and how we're getting a lot of feedback back from your, as you call them, LinkedIn warriors.
Yeah.
That you can specifically put that cage in the location where you're going to get that. So I never knew that before, but I learned a lot just doing this presentation.
So if the patient is somebody like a lot of our patients who nobody else can treat, and they happen to be in dire pain and effectively immobile and aren't moving, instead of treating the picture, we treat the patient. So we're less concerned about how pretty the CT looks later in terms of lordosis angles and all the other stuff, and look at, is the pain gone and does it stay gone?
Number one, as Ken was saying, we have a good evidence by putting the cage on the side that needs to be elevated. We are able to add to discal distance and correct that. For scoliosis, we have the evidence. We published a paper. We can correct 5 to 7 degree. And we have enough data
per level.
For the coronal deformity, that is a question is answered. For sagittal deformity, we have enough evidence to show that we can significantly create especially by combining OLLIF and MISDLI. You have another technique that we invented by going straight horizontally, put the cage mostly in the anterior part of the disc. Now, but I'm not going to get to that. That is like somebody is just throwing mud at you. Now, why do we need the lordosis? We are taking lordosis as an indication that patient is going to do better after the surgery. That is just an indication. And that indication, that connection is not as solid as people think it is or want you to believe it is. But what is even more important, that lordosis as indication for patient outcome. Goddamn patient's outcome. And since we get our patient outcome so soon after the surgery and it's sustained, they have to wait 2 years until they see that the because the initial result is horrible. This patient get a scoliosis surgery. They are told from the start, it takes 2 years for you to recover. What indication do they have for good outcome? They take low doses, they take disc preparation, they take
X-rays.
3D X-rays, that as indication for patient outcome, because it takes them 2 damn years for the patient to really start doing well. We get our results so early and we follow them up so long, we bypass all those maybe or indication and so on and so forth. We go directly to what really matters, which is the patient outcome. And our patient wake up, the leg pain is gone, the claudication, meaning the problem with walking, is gone. And so we don't need the indication, we don't need the parameter to say what the future outcome is going to be. We check the outcome directly.
We don't rely just on leading indicators.
Yeah,
We rely on the outcome.
yeah, and that is exactly, are we treating the patient or the pictures? Amanda made a huge, Amanda made a fantastic comic about that. Please put a link to that comic, okay? So let's go back and, we are almost getting there.
So
Okay.
this was something that we started the conversation off, and I believe that Dr. Abbasi had the same objection, that they do not believe in the effectiveness of indirect decompression. So bottom line is they're concerned that the surgery will not deliver leg pain relief.
It's you. What do you think?
I've seen it. Indirect decompression, you're basically putting the bones back in their natural alignment, giving them their spacing. You're removing the compression by realigning the spine to its natural orientation. What could be more effective?
Now, you're a mathematician, must be, as an engineer. So when you go from 7.4 to 13, so let's say 7 to 14, have you now doubled the area point where the nerve is coming out?
No, the area is a squared value, so you're getting an exponential increase, not just doubling it, but you're getting area is, or the circle there would be pi r squared. So by doubling the diameter, you're taking the diameter squared times the value of pi.
So 4 times.
4 times the area.
As a matter of fact, the math of it is, if you add 2 millimeter, you're doubling it. 2 millimeter or 2.5 millimeter in average is enough to double the area of where the nerve root is passing through.
Actually, we get a lot of patients, probably 60 to 70% of our patients that do call in to schedule an appointment are actually suffering from significant leg pain. So again, we have the data, we have the patient testimonials that prove that, next day, 2-3 hours later, the leg pain is gone. So we actually have our patients go to our website and we give them the links to specific testimonials that say, yeah, my leg pain's gone.
You remember these two?
I do.
Do you want to tell their story?
So I actually came after them. So I believe the husband, the one on the right, actually had a TLIF, an open traditional surgery, and his wife had the OLLIF surgery. And the husband is very jealous that he wasn't able to get that surgery because he saw the outcome of his wife. And he explains that she was only in the hospital for 1 day. He was in the hospital for a week. She was back doing regular activities in 2 to 4 weeks. He was 6 to 8 months. And so he's like, I just wish I would have known about this when I was getting my surgery.
But this is not a singular kind of story.
No, this happens.
Happens all the time. John?
I'm going to go back to what I said earlier regarding the subsidence, and this is where the 7 millimeter difference pre-op, 14 millimeter post-op, and it stays at 14 millimeter, combined with the fact of the patient wakes up, the leg pain is gone, month later, leg pain still gone, year later, leg pain still gone.
Typically, this is one of the highest number of objection to OLLIF by surgeon. That I do not believe in indirect decompression. My answer to that is, it's a famous saying that all the aeronautic engineers have calculated, and they say that the bumblebee is aerodynamically unable to fly. Bumblebee flies never doesn't know of them and flies nevertheless.
Yeah.
And the fact is, just go and listen to any of those 1,213 testimonials. It doesn't matter what we believe or don't believe. The evidence is right out there. We can now explain that's how it's happening, but it is like, you see the sun coming in and out every morning, coming out every night, going out. Or we have been, as a humanity, have been seeing it for thousands of years. Now, we try to explain it. That is that the Helios, god of the Greek, or that is the this and that, and then it's a burning pile of wood and so on. It doesn't matter how we explain it. Next day, the sun is still going to come up and go down as the day before. And this, for us, is as evidence of the sun coming up and down because we see it every day. We do the surgery, they wake up, their leg pain is gone. That's all I need to know. So let's move on to objection 6.
So when we explain that this is a technique for what is known as a 360 or anterior posterior lumbar fusion, it's claimed by some surgeons that we're incorrectly coding it as a 360 because the cage placement is not a true anterior approach, solely due to the fact that the patient is what is known as prone or on their stomach during the surgery.
What do you think? Are we in retroperitoneal space? Which is the definition of the anterior part?
I think that the definition of anterior to the transverse process, we're definitely entering the disc space anterior to the transverse process, which is what a lateral is coded as.
Yeah, and one of the, okay, I'm going to give my answer later. I don't believe you have.
We wouldn't have it.
Yeah, John.
No, same. And I know I'm not supposed to say same, but my understanding is we traverse a trajectory that is anterior to the transverse process through the retroperitoneal space. And the bottom line is Medicare, Blue Cross Blue Shield, everybody else believes that we're coding it correctly.
And they looked at it, and more importantly, we started doing, about 8 years ago, 10 years ago, almost soon. Meanwhile, the very famous doctor in the Dr. Uribe, who is a famous name in the spine, start doing so-called prone laterals, meaning going lateral from the side while patient is on the belly, doing that. With the difference that we published that paper 4 years before Dr. Uribe. And so we have been doing, this for years before him. I think we are just a little ahead of our time. That is why we have to even answer this question. So, but let's move on to objective.
The OLLIF requires too much fluoroscopy X-ray exposure.
Okay. Ken.
It requires more than 0, but a surgeon who's familiar with it and is good at reading the X-ray and minimize that. And I've been involved in TLIF cases that have far more exposure, lateral cases that have far more exposure than we see in OLLIF cases.
You get any of that?
We don't get patients that actually ask questions specific about fluoroscopy, but the minimal amount of fluoro that you use in a 1 or even 2 level fusion is. I don't even think it's a question.
John?
Yeah, I believe the issue is more from the surgeon standpoint, because unlike a patient, the surgeon is going to do this more than once. Okay. And in terms of, as we can see, our average fluoro time is about 90 to 120 seconds. I know there's some comment about an angiogram is literally 30 minutes.
So for people who are interested, I have an album on my Abbasi NSGY Facebook account. Just look for that, where we calculate this thing. The amount of, I do a lot of this surgery, amount of radiation I get is very similar to a professional pilot. As a matter of fact, we get for 1 level about 90 seconds of fluoroscopy time a day. Imagine somebody who does cardiac cath day in, day out. They do a cardiac cath and they give patient about 30 to 40 minutes of radiation. 30 to 40 minutes. We give it 1.5 minutes. Somebody will get a cranial angiogram, usually 15 to 20 minutes of X-ray time. And these were more of an issue in the time that the machines they produced and needed a lot more radiation. The machines that are built today they use so little radiation because we have intensifiers and electronic compensation that this, if you look at the numbers, it's not really anything that I'm concerned of. And you know what? I'm doing it every day. I'm not concerned about that. Now, and as well, when you start, obviously the numbers are higher, but they come down significantly. So, fusion rate.
Yes, so they do not believe that the fusion rate of OLLIF is 98.7%.
What do you think?
Well, I mean, I saw the studies where the radiologists read it.
That's all you need to say.
that's- And it wasn't anybody that was connected to it. They were
Yeah.
totally independent, and that was their finding. But
Yeah.
I believe in the fusion rate because you're not removing all of the support structures that provide blood flow to the spine. You're preserving all those natural structures, and the body doesn't have all this collateral damage that it has to heal before it can focus on creating the fusion.
Mhm. Is it something you hear?
We actually get questions where patients ask us about our success rate. So success rate is a little bit differently, and fusion rate obviously at 98.7, very impressive. Independent radiologists that read it, very impressive. However, success rate, if they're asking us that means that they're typically on their second opinion, where they've done their research and they've found out that there's other surgeons out there where they actually have failure rates that are higher than expected.
Mhm.
And so that's usually their first question is, what is your success rate?
So, John?
So I go back to the fact that I didn't believe it either. When they told us that, but it was two independent radiologists. And truth be told, you know, all of the techniques for lumbar fusion have advanced substantially since, you know, in the last 25 years, where my understanding is 20, 30 years ago, the fusion rate for these open surgeries was 60 to 70%. But we saw in the literature that even other minimally invasive techniques, MIS-TLIF, the XLIFs and things like that, they're in the low 90% as well.
Yeah, and the reason is that we don't destroy the vascularization of the bone. We don't cut all these muscles that contribute to the perfusion of the bone. We don't create dead avascular scar. And all of that, practically, the body has less trauma to recover from, can concentrate on the actual bone growth. But again, you know, it is confirmed by independent radiologists, and other MIS procedure has as well confirmed that that is that high. So
Just
we have
more.
one more.
Okay. So the OLLIF peer-reviewed patient outcome studies are not published in a reputable journal.
So, any comment on that?
We have so many outlets nowadays for news.
Mhm.
We have people that get their news strictly from Twitter. And they believe that, but somehow being published on an internet-based protocol is not acceptable.
Now, is there anything that you're confronted with, Mike?
Not from a patient standpoint, but from a surgeon standpoint, I have been told the same thing.
Mhm.
However, looking at Curious and actually putting papers through Curious, I think is actually very reputable. And I think you're going to get into the reasons why here.
For anybody out there, do they think Stanford is a reputable organization?
That is their
Dr.
venue.
John Adler, Google his name and see who he is. He's the one that created this publication.
And on my side, I just can say Kmart versus Amazon. That's all you need to know. The future steamrolls those who don't want to follow it. And practically, if you look at the numbers of the Curious now publishing versus number that traditional journals are publishing, they are just catching up. I'm just going to say the Chrysler versus Tesla. Well, you will be steamrolled one way or another, but what's important for me is that my patient can go and download and read those papers, and do not underestimate the understanding on the patient. There's something not on our list, and we are going to spend only 2 minutes on that, is about, do we use robots and navigation, yes or no? Just very short. Robot navigation versus what we do.
No, skilled surgeon who can actually have the eye-hand coordination and read the images that they're presented live is going to have much better results than referring to a CT that was done and overlaid onto a patient to create navigation or to drive a robot.
We do not use robots. Our surgeons' hands actually within the instruments that we use in fluoroscopy is a much safer approach than a robot that some people actually said that was run by their 12-year-olds.
Yeah, that is the point. Actually, in one of the conferences, one of these people said, it is so easy. I can let my 12-year-old son run it. Okay, who wants to get operated on their spine by the 12-year-old son of somebody who created that robot? Send us your name. We will refer you.
So I'd like to say, show me the results, the patient outcomes of robotic surgery versus non-robotic surgery, as well as show us the corresponding perioperative parameters from a risk standpoint. From my perspective at this stage, okay, not ready for prime time and strictly buzzwords and marketing. Makes it sexy. Hospital justifies spending another $2 million.
So, and I'm going to tell you as closure that we do use robot. As a matter of fact, we use the most advanced computer in the whole universe for this surgery, which is between my ears. And we use the most advanced robot existent in the whole universe, which is fortunately attached to my shoulder. And we hone those skills, and our surgeon can beat any robot at any time because we care about the skills, and we don't replace skills with a tool. A tool is a tool, it's a tool, but never a replacement for skills. It's an additional and kind of improvement on our skills, but that is the danger. I see it as a danger to replace the skills with a tool. Well, it has been much longer than we expected, but I'm hoping you will enjoy this, because this was a truly coming from our heart in Inspired Spine. For Inspired Spine team, we are
And Vera?
Mike Hansen.
John Siegel.
and I'm Dr. Abbasi. Please return to our series, Essence of Medicine. Thank you for your attention.